Thank you very much, dear chairpersons. Dear colleagues, I think this is a very interesting talk, which has been, allotted to me to present today. This is a very commonly encountered problem these days. And as I was discussing donors with Masselt, our recipient having obesity and fatty liver related problems is increasing day by day. So therefore, this is a thing which we all are seeing more and frequently. So those who are obese, now we have this, metabolic syndrome, mast cell, and also they can have a non-mast cell related liver disease, like hepatitis B, C, can be anything, autoimmune. So there is a combination, and they would have other metabolic problems like diabetes, hypertension, dyslipidemias. A lot of them would have cardiac issues, pulmonary, obstructive sleep apnea, and so on. Generally, they have poor exercise tolerance. So it's like a conundrum where we are really, in a situation where an obese donor comes to us and we are really stuck up. Obese recipient comes to us and we're stuck up. And we have a clear understanding that when you reduce this obesity in any way in a patient, if you can, it reduces the risk of decompensation early on if you pick up. Overall, it improves their overall status, reduces the risk of HCC. Any surgery which you do in them, may it be transplant or non-transplant, that is taken in a better way if the obesity can be tackled before that. There's an excellent review article by Kimberly Watt, one of very prominent persons, one of my colleagues from ILTS, and anybody interested in understanding obesity management which is for the purview of hepatologists will know. I think everybody should be aware of this, maybe surgeons or others involved in managing these patients in the liver transplant setting. And one thing which I have always found which odd is that obesity definition actually is a very fundamental basic thing. But actually, if you see, the Asian definition is different from what we quote in the West. So our Asian definition says that you're overweight when you're more than 23 and you're obese when you're more than 28. Whereas in the WHO definition, which is the West, it says you're overweight when you're more than 25 BMI and obese when you're more than 30 BMI. So this also leads to some discrepancy because the data which you see in the Western world and what we see in our patients, this actually sometimes may not be corroborating that accurately because early on our definitions are a bit different. And I think this is a point which I have always found very interesting. So with the rising incidence of MASLT, dual pathology, obesity, accelerating fibrosis, they have sarcopenic obesity, so their muscle mass is low, and a lot of them have cardiometabolic load and other issues complicating their problems. So there's a whole lot of challenges. Diagnosis, complications, portal hypertension, bleeding, infections, increased HCC risk, higher perioperative risk in general, and cirrhosis specific complications. Those who have got obesity, morbidly obese, their ascites may be a problematic thing to diagnose and to treat, higher risk of variceal bleeding. They may need problems related to OSA and all. Now, pre-transplant optimization is actually not so easy in these patients. In fact, most of us would agree that an obese patient comes to us with BMI, 40, 45. We literally say that, well, nothing's going to happen. This is really the state which we're going to deal with. So it was initially considered that BMI more than 40 would be a relative contraindication for transplantation. And if possible, we need to optimize these patients if we can treat their complications, comorbidities. And let us see. Now, this is a patient who's actually in my ward. This is just a photograph taken day before. And that's the ICU, which has got a beautiful, landscape of the, outside greenery. So this patient, 50-year-old, has mast cell cirrhosis, jaundice, ascites, encephalopathy. ICU, he was admitted to grade 3 HE, now actually out of encephalopathy. He's got hypertension, diabetes with a high MELT and a high CTP score of 12. Child C, BMI 47. So he was very sick. He was in ICU, was on inotropes, had in grade 3 HE. He recovered from that, had sepsis. Family is, very active. His son, and daughter, they're all very educated. The question is, what will you do with this patient? Can you optimize this patient? What you can really do is treat all comorbidities to an extent, treat the ascites part, but otherwise you are really stuck up. So then the issue will come whether we will proceed with the transplant consideration or maybe just leave him like this. And especially if you do a transplant, DDLT is one part. If you're doing living donor, I think most of the surgical teams would not really agree to a patient like this undergoing LDLT. So this is a problem thing which I'm posing to you, and the patient is actually admitted as of now, and I'll tell you what happens later on. Now, for the physician's interest, there are numerous medications which have come, and I think this is also a good news for surgeons that now we can treat obesity in a much better way in these patients as compared to the past. However, all these treatments are to be done early on in the course of the liver disease. Now, beyond lifestyle changes, which is diet and exercise and nutrition, which is important, there are certain medications which have come, and some of them have made a dent in the medical management in our OPD practice. And these are the ones which are going to be game changers. But newer drugs are also coming. So this is a good news for those who are treating these patients in our clinics, which we see. But yes, those who are decompensated at all cirrhotics like this, I don't think any medication pharmacotherapy is helpful. Lifestyle nutritional, I think this is a very standard thing, and I would tell you that anybody who's treating these patients should emphasize strongly the OPD practice. Now, let me spend 2-3 slides on this pharmacological treatment drugs which have made a difference. GLP-1 agonist semaglutide, it reduces the fat, does not improve fibrosis, so it is not really in my list of favorites anymore, although it has been launched in a big way by the companies. It has recently come to India, and you will see that all the pharma companies, 2-3, are very strongly promoting in our practice. Second drug, which is co-agonist of GIP and the GLP-1, which is tirzepatide, that is one drug which has shown huge promise in reducing fibrosis. And there's thyroid hormone receptor beta agonist resmetirom, which also has shown huge promise in reducing fibrosis. Metformin continues to be safe, and in decompensated cirrhotics, really, there are very few drugs which you can, really prescribe. I'll just quickly skip over this. This is, just a NEGM study where tirzepatide was shown to be highly efficacious in improving fibrosis in these patients by more than stage 1 without resolution of MASH, with no adverse, progression, and well tolerated. And then this was a very, very important trial on resmetirom by Stephen Harrison, where they showed that a dose of resmetirom, which is titrated to these patients at about 100 milligrams, is actually quite effective in, again, not only resolution of MASH, but also reducing fibrosis more than stage 1. So these two drugs are now available in our Indian practice. They are the ones which we are using in our patients as and when needed. And then there's a question of bariatric and endoscopic interventions, which is all discussed in all meetings, but I've never found a good answer to this. My surgical colleagues can really speak better on this. Bariatric surgery, only one line I would say: consider a bariatric intervention in an obese cirrhotic if it's in child's A and does not have significant portal hypertension. Those who are child BNC, large varices and all, I don't think they are in any way suitable. An algorithm which is there, it's all there, but I think bariatric intervention is not easy in these patients. Now, this was something which we did a long time back in Vedanta. This was exactly 12 years back. This was a case in a morbidly obese patient, BMI 48, was with me. He's from Ludhiana, Mr. Raj. And he was very keen for a transplant. So what we did was we put an intragastric balloon in this patient, and in 3 months' time, this was a bioenteric balloon which was pushed, and 3 months his BMI reduced from 48 to 39. His HbA1c, which was very high, 9.2, came to 5.4. His blood pressure got controlled. He was much better, and we had a organ available in Medanta. I was working at the time with Dr. Soin. And we called him he was a very rich person. He actually took a chartered flight, came to Medanta, and we did a transplant overnight. Before the transplant, we removed the balloon endoscopically because, that can be a problem in the surgery. And he did extremely well, and he lived till almost 10 years. I think only last year he passed away with some other problem. So that was the first. And this I published, I presented this as a letter to editor in liver transplantation. And in 1 week's time, they actually accepted it and they published it. This gave us some, more zeal. And then we presented this, we did this study in a more elaborate way. In 2016, we presented this study in Indian Journal of Gastroenterology of 8 patients who had cirrhosis, BMI more than 40 or between 35 to 40 with a low GRWR. So that was the two combinations. And again, we put the bioenteric balloon in these patients. They were sicker patients. You can see that out of these eight, six were males, two were females. BMI 43 was the mean BMI. Uh, Most of them had decomposition except one patient. They did not have any severe varices. Luckily, none of them had gastric varices. They generally tolerated it okay. Weight loss was there in all except one, and five of them went on to undergo liver transplantation, and they did reasonably well. But subsequently, I've seen that it's been almost a decade now that this intragastric balloon never took off. We also planned a study in NASL with Ajay as a part of ICON, but it never actually got through because it was appreciated that the tolerance to this balloon is not so good. Although there's newer modification of this intragastric balloon has come. I mean, we have to Chawla to Saraswat, they would be aware. Sir, but we never have really got into this. And I was chairing a session in Boston ASLD as a program chair, and there this was a session of obesity and transplantation. When I actually put our experience, they were not at all excited and said, no, we can't be doing it. So just like that, maybe we need more awareness, and one day this may come off as an important tool. So there are several post-transplant challenges in patients. They will gain weight after surgery. They will have a lot of problems, recurrence of NASH, and lifelong. They have to be really careful with their nutrition and lifestyle. Now this is a very interesting study which my colleague Charlene had and Subhash had done with. They did obese recipients more than 100 kilograms, and the GRWR in these patients was in three groups. So 56 patients out of 916 who were considered, that is 6.5%, had obesity with weight more than 100 kilograms, GRWR less than 0.65, 0.65 to 8, and more than 8%, three groups. And then they did a analysis. What was shown by this paper that despite obesity and smaller GRWR, the post-transplant outcomes were similar. Very interesting. And on comparing the three groups, what they found that the absolute graft weight, which was there, was one of the most important factors as a predictor. And the conclusion was that graft with low GRWR can give satisfactory results in obese patients undergoing liver LTLT. So this is something in obesity paradox, which is very important. Now, this is actually a very interesting slide, which I want to share with you. This is a slide of our first dual lobe transplant in our country. When I was in Gangaram Hospital, I was treating these patients, Apu Chetir from Salem, and one of very favorite patients of mine. And Dr. Soin and Subhash both were there. A right lobe from his son, left lobe from his cousin, I think it was a niece. And why it was done? Because he had a high BMI and a very low GRWR with only one graft. So that was the evolution of dual lobe transplant, but again, it never picked up in our country. We thought that there's no point having two donors coming up. And now with better experience, our surgeons are very expert. And with lower GRWR, even ultra low GRWR, they are also doing successful surgeries. So in my last 2-3 slides, I will tell you how things have changed. So that was my colleague, Sajil colleague in Gangaram, nearly about 18 years back, doing a dual lobe for a patient with obesity and low GRWR. And today I have this lady who's 52-year-old from Somalia, had typical hepatitis B cirrhosis, decompensated. I admitted her for about 10-12 days in my own care with a BMI 41, child C, CTP score 11, male 22, sick lady, had hepatitis B related cirrhosis, all those complications, bleeding, ascites, achiever, all there. So an MRI showed a lot of collaterals and a very shrunken liver. You can see a lot of fat component all across there. Now, so there is a change in the concept, the surgical expertise, the confidence, how good our surgeons are these days. This lady now, with this sort of thing, underwent a limb node liver transplantation just about, I think this is our 26th of September. Sister donated, she's from, again, she also had high BMI of 32, but very fit lady. And these are a couple of details. But one thing I noticed that ascites of 6 liters. So the ascites really contributes to weight in a recipient. Please note that. Expected graft weight was 910 and GRW was 1, and a modified ATLO was done. And this lady just post-operatively had an excellent recovery, extruded on day 1, triple immunosuppression, now stabilizing, his graft is functioning well, and no pulmonary, no cardiac issues. So there is a sea change in the concept where I had experience, because in my last 30 years of liver transplant practice, same colleagues, excellent surgeons I have been associated with. I'm blessed to have been working with the best surgeons who have in the country. And they had done a dual lobe transplant about 18 years back. A similar patient comes today to Subhash, and he does a right lobe living to liver transplant, and he says, obesity, fine, I'll take care, don't worry. And believe me, the other patient who's there, I just showed you in the initial part, who's BMS 47, he has been, optimized. I'm not sure, maybe he will also have a right lobe transplant. But the message is that the truth? Is it the right thing to say? Well, in summary, these obese cirrhotics are very common now with rising MSLD. All of us are encountering them day in, day out. And besides the standard nutrition exercise, which is to be really done in the early part, once they decompensate, we are in trouble. Some drugs, all surgeons should also know today that these GLP-1 agonists, the co-agonist, tirzepatide, resmetirom, they are the drugs, and newer drugs are coming also. So this will really be, game changers in the early on management. Bariatric things, I am not sure. Endoscopic, my senior colleagues, Dr. Chala, Dr. Saraswat, they will have guide me as to what is the right thing to do. And of course, we need to have BMI less than 40 as an ideal thing, but in those with BMI more than 40, carefully selected patients can undergo successful living donor liver transplantation in highly experienced centers. And I think with this, I will close my talk, and any questions I'll be more than happy to answer. Thank you very much.